Today I'm going to talk about orbital coronary atherectomy. As we all know that the biggest difficult and challenge for the successful BCI is the calcification and the heavily calcified vessel. So at the beginning we're going to know what is the calcification itself. Coronary calcification is accumulation of the calcium in the heart artery. That happens after plaque, fat, and cholesterol and other substances forming in the arteries, atherosclerosis over years. The calcification can affect our coronaries. BCI of calcified coronary artery disease will reduce the procedure success and increase the risk of complication either early or late, because the calcification can impede stent delivery and deployment and lead to stent under expansion and malposition, and it might directly damage the stent. So patients who have some of this risk factor, they might get coronary calcification. Patients with CKD, diabetes is playing a major role in the calcification of the arteries. Hypertension, high cholesterol, obese patient and patient with a strong family history of coronary calcification, they might get the calcification. Smoking as well. So the way of diagnosis, we have cardiac CT. Cardiac CT is non-invasive procedure, and based on the findings on Agatston scale, we can say that the calcification is either mild or moderate or severe. So from 1 to 99 of the scale, we can consider it as a mild calcification. From 100 to 299 is a moderate, and 300 and above we'll consider it as a severe calcification. And we have IVUS and OCT. So the method, we have different methods of breaking down the calcium. We have, and each one of them has its own criteria to be used. We have scoring and cutting balloon, shockwave, orbital atherectomy, which is I will talk about today, and we have rotational atherectomy and laser. So at the beginning, what is the orbital atherectomy? It's an adjunctive therapy used to prepare the calcified lesion before BCI. The goal of the preparation is to modify calcified plaque, which is achieve the lesion compliance and allow for balloon and stent well expansion in the segment where is the calcified. Here are the components of the orbital. We have a guide wire, orbital pump, and orbital atherectomy device, and we have Viber slide lubricant. That lubricant will be mixed with the saline to prevent the friction to not damage the wall of the artery. As you can see here, we have the drive shaft. It's a conic shape which can cross the lesion safely without damage, and to facilitate the crossing the lesion, we have the crown, which is having the which is having 360 movement. It's moving around itself and around the artery, and it's designed to treat the vessel or the calcification circumferentially. Here is the mechanism of action. As we can see, it is moving around itself and around the wall of the artery.
Cranes and lights with people much time. Once I'm there, they last. What? If the balance at the start is here, you can get your thanks. Come piece around the
After the preparation of the artery, here is the time to place the stent with a good stent expansion.
Oh, like they did not.
The orbital has a dual mechanism of action, atherectomy and calcium. With the atherectomy, it's a bidirectional differential sanding to reduce the superficial calcium in the intimal, and it will reduce the calcified plaque and minimize the damage of the medial layer. The calcium modification by pulsatile forces, it's treating the deeper calcification by pulsatile forces to contribute contribute to the compliance changes. Here is a quick comparison between rota and orbital. Rota has a burr spin concentrically and a front-cutting monodirection burr. But orbital has eccentrically mounted diamond, which is, as we said, it's bidirectional movement around itself and around the vessel. Okay, here are the complications that might happen: perforation, dissection, wire interact. And here is the algorithm of the calcified lesion. If the calcification by OCT, we can say that it's deep calcification. If it's deep, we can go with the NC scoring balloon or cutting balloon. If it's success and the lesion prepared, we can go for stenting. If it's superficial, we have to consider some criteria to say some criteria. If it's met, we will go with the way, and if it's not met, we'll go with the other way. So if the superficial calcification not meet the criteria, which is the thickness not more than 0.5 millimeter and the length less than 5 mm, we'll go with the scoring and cutting balloon and stent it. If the superficial calcification is more than 0.5 millimeter and the length is more than 5 mm, we'll try to go with the balloon. If the balloon cross, we'll go with the shock wave. If the calcium fractured, we can go with the stent. But if balloon not uncrossable balloon, we'll go with the atherectomy therapy, which is orbital or rota. And here, rota ablation, if the balloon not crossable, and good for ISR, because as we said, it's monodirection and front cutting will not damage the struts of the stent. But orbital can go with the long diffuse calcification with the large vessel and ostial aorta ostial lesion. And what we need to prepare before the procedure, we have to prepare our preferred approach, which is a radial or femoral. Orbital can go and compatible with the 6 French and above. Imaging equipment, IVUS or ACT. We have to prepare the lubricant with 1 liter saline and 20 ml of that lubricant, as I said, to prevent the friction. TBM standby, closure device, and echo machine. And here is one of the cases that we've done in our cath lab. Patient came, 58 years old, male patient with diabetic and hypertensive dyslipidemic, smoker, and came as a case of exertional angina class 3. ECG showing ST depression with ejection fraction 40%.
I think it's stop.
As you can see here, it's in the circ. It's a good circ, diffusely diseased, calcified. Here, as you can see, here is the burr of the orbital. And here, after we did the multiple session of orbital, we prepared the area well, and we put a stent, and this is the final picture. Thank you.